It's a great pleasure to introduce our next speaker, Dr. Doug Morgan. Doug is the Professor of Medicine and Epidemiology and a Division Director for the Division of Gastroenterology at the University of Alabama, Birmingham. Doug and I were fellows together 30 years ago at UCSF, and at that time, he was really focused on healthcare disparities, especially in cancer. And it's remarkable that he's never wavered. And he's been dedicated not just to gastric cancer, but also to reducing disparities. And that's evident in the work he's done, especially in the Honduras and other parts of Central America. So I'm really pleased to have him here as a speaker, but also speaking on societal guidelines. I think it's for the ACG then, so welcome.
John, thanks very much. I'm humbled. And I want to thank Joo Ha and Rob for the invitation to be here. It's really great to be here at this important event. The title of my talk is the American College of Gastroenterology Guidelines, Synergy and Potential Impact on Gastric Cancer in the United States. I'll be talking about 3 guidelines and the synergy between them. Which are either published or on the way to be published. First guideline, led by Bill Che, is the update on the treatment of H. pylori infection, recently published. The second, and really the focus of my talk, is the IMPRESS guideline, or the quality indicators for upper GI endoscopy. And then lastly, the ACG Guidelines on the diagnosis and management of gastric pre-malignant conditions. This is pre-IMPRESS, so to speak, and so my comments will be general. We have, I think, an important and diverse co-authorship team, both international and multidisciplinary, gastroenterologists, gastroepidemiologists, advanced endoscopists, and pathology. We're at an exciting time, and that's really why we're here, and I think we do have a chance to make an impact on gastric cancer in the United States. Gastric cancer represents a major U.S. cancer disparity, and intentional prevention programs are needed. We've got the guidelines coming out, which will synergize with the AGA efforts. And in parallel, we have advances and ongoing technology advances in the diagnostics and therapeutics related to endoscopy. And behind that is really a surge in precision gastric cancer targeted treatments. Before jumping into the guidelines, I always step back, and this will be an echo on a theme from this morning, but what are our goals? Where are we hoping to get to? Certainly, gastric cancer has been highlighted as an outlier or a disparity with respect to 5-year survival. The Concord initiative out of the UK, tied to the WHO, is a global data warehouse for survivorship data. And gastric cancer in the last version, Concord 3, was highlighted as an outlier because of this wide range globally in 5-year survival rates, from 10% in much of the world,
10 months.
and then in North America and the US in the mid 30% range, and then in East Asia approaching nearly 70%. So what's our goal? Can U.S. 5-year gastric cancer survival rates push above 40 to 45% in the near term? And I would postulate and posit that this is feasible, and that's the principal reason why we're here. And as was mentioned this morning, it's not so much a decrease in incidence, it's really a shift in parallel of the stage of diagnosis of gastric cancer. Gastric cancer is a major cancer disparity. This is an important slide that underscores that the incidence rates are 2 to 13 times higher in non-whites and the majority minority populations. The other key point here is just the granularity that we need, and we're starting to get into the U.S. to allow precision screening and surveillance. And here we're beginning to get granularity with respect to East Asian populations.
So here's our cervical branch, which is...
But there's still needed data. For instance, in Hispanic populations, we know from the incidence rates throughout Latin America that there's a wide range. The bulk of the high incidence areas are along the Pacific, from southern Mexico down to Chile, Mesoamerica, and Andean South America, whereas the incidence rates along the Atlantic, Argentina, Brazil, and the Caribbean are much lower. Another point is there are probably two Mexicos. There are probably 1/3 of Mexico, although the data is not great, is of higher incidence, whereas 2/3 of Mexico is of lower incidence. So we need precision here as we think about the 10 million immigrants from Mexico that are in the U.S. And also, our African American populations have a significant burden of disease, and we certainly see this in the Southeast. In Alabama, for instance, African American males have nearly 4 times the incidence rates versus whites. One of the themes that we saw this morning is with population incidence rates approaching 10 or 12, that is considered or labeled a higher incidence population or a high-risk population. Now, immigration is a part of the story in terms of the cancer disparity in the U.S., and this meta-analysis and subsequent studies have underscored that those who emigrate from high incidence areas to low incidence areas, such as North America, maintain the risk of their host nation. Now, what does this mean in the U.S.? It means about 30% of our foreign-born immigrants in the U.S. come from high incidence areas and are at higher risk for gastric cancer. And there are 4 high incidence regions that have large U.S. immigrant populations. Mesoamerica, which is southern Mexico and northern Central America, Andean South America, East Asia, and then Eastern Europe and Russia with a band down into Central Asia. I'll highlight Mesoamerica and Central America because it's really unique from a U.S. perspective. It is a LMIC region, a low resource region, which has a high incidence of gastric cancer and a large U.S. immigrant population. And that's really, again, from the U.S. perspective, unique globally. The core at-risk population in the region is about 45 million. And if you include southern Mexico, it's much higher than that. And that's linked to an immigrant population of between 5 and 10 million in the U.S. Now, the other aspect that gives us a bit of pause, and I think this is an appropriate commentary, is in and around the ethics of cancer screening based on race and ethnicity. And in this recent commentary, gastric cancer and esophageal adenocarcinoma were used as examples, so to speak. And here you see in black are the average incidence rates of all comers, and you see this flip in terms of the racial disparity in gastric cancer, the opposite or mirror image of esophageal cancer. Now, the authors, I think, appropriately highlighted the benefits and the potential harms of screening by race and ethnicity. Certainly, benefits, beneficence, autonomy, and justice come into play. Potential harms have to do with stigmatization and miscategorization. And as we think about screening by race and ethnicity, this is really where we need granularity, once again, in our very diverse and heterogeneous U.S. immigrant populations. The authors concluded that we should proceed with caution. And I think this is reasonable in the short run to risk stratify based on race and ethnicity with respect, say, to gastric cancer. But in the longer term, we need better biomarkers for screening and surveillance. Now, moving on to the actual guidelines, both the gastric pre-malignant condition guidelines, GPMCs, and the quality indicator guidelines, there's basically 2 buckets, and this is what we've been discussing in the morning session. One is risk stratification, and the other one has to do with quality endoscopy. We've discussed race, ethnicity, and immigration, but I'd like to, again, underscore as we think about risk stratification is the importance of family history, particularly when it comes to the risk of progression from metaplasia to adenocarcinoma, and then some of the hereditary syndromes. I think there's an increasing appreciation of the hereditary component, and I think this study from Japan, a large cohort, large biobank, which underscored the importance of the BRCA gene family, the homologous recombination DNA repair genes, and the importance in the setting of H. pylori infection. Here, with HR proficiency in the setting of HP infection, the lifetime risk of gastric cancer is modest at 14.4%, and this jumps quite a bit to 45.5% in the setting of HR deficiency and chronic HP infection. So this reminds us, particularly in the clinical setting, to have a lower threshold for referral for genetic syndromes, and to keep the familial gastric cancer syndromes and the hereditary cancer syndromes with higher gastric cancer risk in mind. So I think this field is developing, and I think as we try to understand this 10 to 15% of gastric adenocarcinomas that have a familial component, I think the germline mutations will play an important role and may ultimately become part of our screening and surveillance. Moving from risk stratification to quality endoscopy, we've had some nice summaries today, but when you think about a quality indicator or a metric, what is feasible, particularly in the short run? There's certainly evidence with respect to exam duration, i.e. dwell time in the stomach for inspection, and the increased rate of detection of neoplasia, but is that practical? It's not like the colon. So in the short run, as a surrogate for quality, photo documentation makes sense and is actionable. Could we arrive at a metaplasia detection rate in our higher risk population someday? Possibly. Now, the other components have to do with the need for high definition white light endoscopy with image enhanced endoscopy in our higher risk populations or in the majority of endoscopies. And in the US setting, as we've discussed today, that's primarily NBI. And then Sydney protocol-driven or directed biopsies are also important. I think in the short run, when we think about quality indicators, the Sydney protocol is a reasonable first step. And I think our academic centers in the US that are using Olga and OLGIM, I think as that develops, we'll get a broader body of evidence. But in the short run, I think it's too big of a jump to include Olga and OLGIM as a quality metric currently. Photo documentation is important and is a priority indicator in the new quality indicator guideline, as is biopsies via the Sydney protocol. For the gastroenterologists, I think a reasonable approach is a single insertion with 2 bites at each of the 5 Sydney sites, and then placing the antrum and incisure biopsies in one jar and the corpus biopsies in the second jar. That increases the sensitivity for H. pylori diagnosis, for gastric pre-malignant condition diagnosis, and also facilitates the diagnosis of extensive atrophy or intestinal metaplasia. Now, as we've heard this morning, I think the use of NBI can help us direct our Sydney biopsies, okay? And that increases, again, the quality of the exam overall. This is where we've been the last 5 years, at least in Europe and the US. We're excited to learn about MAPS 3. That's great news. I'll comment that the AGA guidelines, I think one of the, we can go on about the critiques, but in a way they weren't really actionable. But I do think that the technical reviews at that point in time were of value due to the deep dive in the literature and therefore identifying areas for needed research. Now, moving on, just to discuss these three guidelines, I'll start with in general terms, with the GPMC guideline. We've talked about risk stratification and quality endoscopy, which will be incorporated into the guidelines. I think the core recommendation will indeed be for surveillance at the 3-year interval for high-risk patients with gastrointestinal metaplasia. High risk is either defined by histology in complete intestinal metaplasia or corpus extension intestinal metaplasia, or patients with intestinal metaplasia on histology that have clinical factors that place them at higher risk. And this includes those with a family history, those that are foreign-born from high-risk areas, and then a high-risk race or ethnicity in the U.S. with a focus on the major minority groups, East Asian, Hispanic, Black, and American Indian populations. Now, an aspirational goal is indeed endoscopic screening for gastric cancer and premalignant conditions. Ideally, 45 is about the right age for 2 reasons. Number one, in our higher risk groups, metaplasia is highly prevalent at age 45. And then secondly, it also synchronizes with our colonoscopy screening practices. And again, the aspirational goal for possible screening would be in individuals with a family history or higher risk populations. What about adjunct interventions? The primary one is H. pylori eradication. And then secondarily, behavioral interventions are more difficult, but certainly a focus on tobacco has the strongest evidence behind it. Currently, we do not have chemoprevention agents for gastric intestinal metaplasia, although a number of trials are underway. Secondly, the H. pylori guideline. In this update, the specific indications related to gastric cancer prevention have been carved out separately, and while it's not an exhaustive list, I think it is an important list to remind practitioners of the importance of the connection between HP and gastric cancer. Now, the quality indicator guidelines, I think, have a chance to change practice in the United States. The quality indicator documents are medical documents or legal documents, and they're also potentially tied to reimbursement. So it does have a chance to alter practice. Now, the document presents quality indicators with specific performance targets in the practice of upper endoscopy, and integrates new data for existing quality indicators and introduces new indicators as appropriate based on interval progress in the field. The usual targets run between 80 and 90% in terms of performance, and there are prioritized indicators which are associated with a wide variation in practice and outcomes. And it's important to understand that this is a general endoscopist or general document for the performance of upper endoscopy, but does not include, say, for instance, ESD or endobariatrics or third space endoscopy. Now, in the last iteration of this for upper endoscopy, there really were not quality indicators related to gastric cancer prevention. So this is a big change. There are 7 quality indicators. The only prior one had to do with gastric ulcer margin biopsies. So that is again included, but in this version, there are metrics related to upper GI photo documentation, related to either the biopsy or resection of larger polyps, and then the documentation of the H. pylori testing and eradication plans. And then there are 3 specific indicators related to gastric premalignant conditions. One is the use of high-definition white light endoscopy with image-enhanced endoscopy. And again, that has to, in our setting, that implies MBI. and then also the use of the Sydney protocol with systematic biopsy sampling. And then lastly and importantly is the documentation in the medical record of the surveillance plan, either yes or no. So these are 7 indicators out of the total of 29, 2 of which, as I mentioned, are priority indicators, and that is photo documentation and the use of the Sydney protocol. Now, one of the challenges, as we touched on today, has to do with pathology reporting, because a surveillance plan really depends on the documentation of H. pylori status, the documentation of the severity of atrophy or metaplasia, the subtype of intestinal metaplasia, and the anatomic extent of the gastric premalignant conditions. So this is, I think, an important implementation challenge, and it requires both local conversations between GI or gastroenterology and pathology, but also society to society conversations. And I would say the latter, society to society conversations are being initiated, and so I'm hopeful that we can move forward in this arena. So proximate goals, I think the synergy of these 3 guidelines, which is intentional, is important, and will synergize nicely with the AGA updates. And I think we hope, everybody in this room today, hope that there will be a paradigm shift in the U.S. On multiple levels. Certainly the implementation of the guidelines is important. We have been, over the last 2 years, in conversations with GI Quick, the National Voluntary Reporting Endoscopy Quality Database, and I think they'll be able to move forward sooner than later. We've also been in conversations with some of the EHR platforms, such as Provation, and they're also ready to activate. And then certainly, I think in the integrated health systems, be it Kaiser or the VA, advocacy will be helpful there also. Provider education is a theme that's important and has been discussed today. And then a rollout of US-based evidence based on pilot studies. So I think the future is exciting. We have a major cancer disparity. We need intentional programs. I think we need 2 things. We need to implement the guidelines, and then we need US data based on studies. And in parallel, I think research in the domains of biomarkers, H. pylori treatments, and endoscopy technologies is needed and is exciting. Thank you very much from UAB, where the gastroscope was invented, among other things.